And I think this is where the first poll question comes in of, what is, or what % of patients with diabetes will die from cardiovascular disease? You hear about it, people harp about it. I'm giving you this presentation, but what is the actual number? So I'm going to see if I can pull up the Slido and see. Is there any way, Richard, that I could see how many people have answered the question or how much response?
Yeah, absolutely. I've just started the poll there. What % of patients with diabetes? We can also we can switch screens as well to show people's responses. So that's on the polls tab. What % of patients with patients with diabetes will die? Okay, we've got some votes in. Yeah, coming in. Would you like those to be displayed?
Sure, why not?
Yeah, just give me a moment. Okay, I'm just going to tell you that we have majority of answers so far congregating around one answer. We do have a strong majority. I'm not trying to build up the suspense here, but I'm just talking through while we get the Slido up. Here we go. Present mode. You guys are saying. Can you see that, Nicola?
I can. Excellent. So yeah, I think the majority here are clustering around the correct answer, which is 70%. And so that is a huge number if you think about it. And we're kind of going to circle back on this later as well, but to spoil the surprise, we have no cures and no treatments, just delay people. So I think, Richard, we can swap back to the PowerPoint as well. Sorry if it's a lot of work. But
no, it's all, just give us a moment.
For sure. Cardiovascular disease and diabetes is the leading cause of death. Although patients will be affected by all those other kind of complications I had listed, it is the heart that's going to kill you. And ideally, we would like to be able to treat it and prevent it so that we can extend patients' lives and improve their quality of life. However, we're just not there yet. And that is what fuels a lot of cardiovascular research in diabetes.
Just give me one moment. It's coming up. Here we go. I'll get you onto the right one.
All good.
70%. That's, yeah.
2/3. I'm going to skip ahead here.
Yeah.
Cool. So before we discuss how diabetes affects your body or how it leads to dysregulation or how dysregulation of blood sugars affects the body, I think we should circle back and make sure that we're all on the same page about how blood sugars are normally regulated. So here we have a person, they'll eat the meal, their intestines and body will break it down into the macronutrients and absorb it, and this will lead to an increase in blood glucose. And as I've mentioned earlier, diabetes occurs when we can no longer regulate blood glucose. So if we have this increase in sugars, we need to activate a response to decrease it and bring it back to normal. And this is mediated by the pancreas, which produces a hormone called insulin. So if our blood sugars increase, our insulin levels will increase, and insulin acts on the body to try and bring glucose back down to normal. And the way it does so is by acting on 4 specific tissues. And insulin only acts on your muscle, your heart, your fat, and your liver. So if you look at insulin on the brain, it doesn't really have an effect or doesn't have a major one. And the way that insulin can bring sugars back down to normal is through 2 actions. It has an on-switch action and an off-switch action. So insulin's going to turn on the processes which use glucose, because if we use glucose up, that'll then lead to lower blood sugar levels. And the way we use glucose is by breaking it down to make energy and by storing it as other molecules. Simultaneously, insulin's going to turn off the processes which increase glucose and increase the use of other fuel sources. So, sorry, it's going to turn off the processes that increase glucose production. I misspoke there for a sec. So things that lead to glucose release or glucose synthesis will be turned off because we don't need to make glucose when we already have some glucose in the blood. And altogether, these responses will lead to a reduction in blood glucose or blood sugars. So again, insulin is the hormone here that promotes the use of glucose for energy, stops the use of other fuel molecules, and it will also activate processes that need energy, like protein synthesis or cell replication. And the reason we need to do this is because long periods of high blood sugars are deleterious to the body. And so when this process gets dysregulated or dysfunctional, we can end up with diabetes. And you've heard of, I presume, type 1 and type 2 diabetes. Type 1 diabetes occurs when there's a problem with actually producing insulin from the pancreas. So the issue is a little bit earlier on in this pathway, whereas type 2 diabetes occurs when insulin is produced, but it can no longer act on its target tissues. And we can look at that a little bit further in the next slide. So to kind of differentiate type 1 versus type 2 diabetes a little bit more, type 1 is an autoimmune disease where your immune cells destroy the cells in the pancreas, which produce insulin, and this leads to an absolute lack of insulin production in the body. Whereas in type 2 diabetes, patients will still produce insulin and they're going to have very high levels. They just won't be able to respond to it. And this is what leads to a bit of difference in how they present and how we treat the diseases. Type 1 diabetes tends to occur quite a bit earlier on in life, but type 2 diabetes, although previously it was diagnosed after the age of 40, I've heard and seen patients as young as 5 or 8 years old being diagnosed with it. So it is trending quite a bit younger in some areas of the world. And again, type 2 diabetes is a bit more common. The approximate prevalence is 5%, but there's a huge regional and racial variation. So that is a very gray number. And then in terms of inheritance, type 2 diabetes actually has a stronger genetic link than type 1. And I bring this up because oftentimes I hear people ask, when distinguishing type 1 versus type 2 diabetes, which is the one that people are born with, versus which is the one that you should shame someone for. And I kind of bring that up that it's interesting that type 1, although is usually thought of as the one that has a stronger genetic link, when we've actually done the research and looked at it, this genetic link with the genetic link in families is stronger with type 2 diabetes than with type 1. Again, feel free to read up on it more if you're interested in this topic, but I thought it was just a fun fact or a common misconception. And when it comes to treatment, I won't go too far down this pathway, but they are treated differently because there is a different cause of the disease. So with type 1, we'll replace the insulin, whereas with type 2, we're going to try and modify lifestyle and give drugs that lead to glucose excretion. And then just to kind of help, again, stratify the differences between these two conditions, type 1 diabetes tends to cluster in families that have an increased risk of autoimmune disease, like rheumatoid arthritis or thyroid disease, which you may have heard of, whereas type 2 diabetes is a little bit more common in families that have high blood pressure, fatty liver disease, or difficulty regulating their blood lipids. Type 1 is an autoimmune disease, whereas type 2 is a metabolic disease. And the last type of diabetes I'll briefly flag on that you may or may not have heard of that may be of interest to some people is something called gestational diabetes, which occurs in women which are pregnant. Their blood glucose levels can get so high that they actually meet the criteria for diabetes, but then after giving birth, their blood glucose levels go back down to normal. And this occurs because of the hormones which increase during pregnancy. They cause the mom's body to become insulin resistant so that blood sugars can go higher in mom. This enables more blood glucose to go into the baby so the baby can grow. But this process becomes so extensive that it actually leads to risks in mom and in baby, which I've listed down in the bottom right-hand corner here. For the purposes of this presentation, I'll just be talking about type 2 diabetes from here on out. But if you're interested in the topic, gestational diabetes is an interesting and unique area you can continue reading up on. So we've talked about how is blood glucose normally regulated. Let's touch on what happens in type 2 diabetes. So patients or people may have an increased genetic predisposition to diabetes. They may have a high caloric diet. They may have a stressful lifestyle, a sedentary lifestyle. They may have problems sleeping. And all of these factors will come together to increase blood glucose. And as blood glucose increases, insulin increases as well. However, these factors on the left never go away. You can't change your genetics. You maybe have a really stressful job that you can't leave. And as a result, glucose levels will never return to baseline and they remain chronically elevated. And this means that your insulin also never returns to baseline and remains chronically elevated. And the way our body responds to signals or to hormones is it looks for changes in hormone levels it doesn't actually care about the total or absolute level. So even if your insulin is really, really high, if it never dips back low and then increases, eventually your body will say, well, there's no change in this hormone, there's no change in this signal, I'm going to stop responding to it. And so because insulin is always high, 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 and high, eventually your tissues stop responding and your blood glucose continues to remain elevated. And the consequence of this insulin resistance, or the consequence of your body stopping to respond to insulin, is now we can no longer get rid of or activate the mechanisms which decrease glucose. Similarly, we then also, remember how I mentioned earlier how we had the turn on switch and the turn off switch? We lose both of those functions. So insulin doesn't turn on the processes which use glucose, but it also doesn't turn off the processes which synthesize glucose or increase the use of other fuel molecules. So we kind of get a mixture of effects going on in the body, which lead to various problems down the road. And I really want to drive this point home. So we're going to look at it again using some of these previous pictures. So looking at the organs which insulin affects, if we have no insulin signaling, these processes before, which should normally increase in response to insulin, actually decrease. And similarly, the processes which should be turned off end up turned on. And so there's a complete backwards response when insulin isn't able to signal. And as a result of this, your blood sugars tend to continue increasing, and your pancreas will see these high levels of glucose and will pump out even more insulin to try to respond, but your body is insulin resistant. And then what is important to cardiovascular disease is this final point down in the bottom, is that your blood fats or your blood lipids tend to increase as well. And this is because normally insulin will turn off the breakdown of fat when we have high sugars. Sugars and fats are both energy sources. If one is high, we turn or we decrease the other one because we don't need to have two energy sources at the same time. That's inefficient. So normally after we eat a meal, our sugars increase and we'll decrease the breakdown of fats because we want to use sugars, and insulin orchestrates that response. And then similarly, when we're not eating a meal, our blood sugars are low, so we increase our fat breakdown, so we have fats as our fuel source. But if we don't have insulin to regulate this seesaw activity between fats and sugars, what happens is that we have sugars increase, and then we have fats increase, and this leads to disease in the body. And it's specifically this increase in fat that leads to diabetic heart disease. So that kind of sets the stage for the first part of what happens in diabetes. We can now start talking about what happens in the heart and how these high blood lipids actually affect the heart and why they lead to problems. So looking at heart disease and diabetes, as we've said, it's the major killer of patients who have heart disease is the major killer in diabetes. And there's no cures and no treatments. We can kind of delay it and we can try, but really what we're doing isn't good enough compared to many other diseases and conditions. And diabetes predominantly increases the risk of 4 different types of heart disease. There's ischemic heart disease, which you may or may not have heard of. This is also known as coronary heart disease. It leads to heart attacks or myocardial infarctions. There is a condition called diabetic cardiomyopathy, which we're going to explain further in the next slide. And diabetes also increases your risk of high blood pressure, which can then affect your eyes, your brain, your kidneys, and further damage those organs, in addition to the damage that diabetes causes. So you can almost get a double hitter effect. And then these 3 heart diseases or heart conditions can increase your risk of heart failure, which is the stage 4 cancer of heart disease, is how I think of it. So let's kind of look at some of these diseases a little bit further so you guys have a better idea of what they are. So I really want to differentiate ischemic heart disease or heart attacks from diabetic cardiac myopathy. So the first way I like to think of the difference is that they affect different parts of the cardiovascular system. Ischemic heart disease is a blood vessel disease, whereas diabetic cardiomyopathy is a heart muscle disease. So in the heart, we have blood vessels, which deliver blood, and then we also have the muscle cells, which contract and push the blood forward. These diseases occur in different parts of the organ. In ischemic heart disease, in the blood vessels, you form a fibrous fatty plaque that then can eventually get big enough to block off blood flow and cut off circulation to the muscle. Whereas in diabetic cardiomyopathy, it's an actual defect within the cells. So the definition is quite stupid or very bad at the moment because we're still learning more about this disease, but it's defined as an abnormal heart structure and function in the absence of all other cardiovascular diseases. So we'll explore this a little bit further, but what tends to happen is, as we've mentioned in diabetes, we have high blood lipids and high blood glucose, and this will lead to the death of heart muscle cells. It'll lead to fibrosis or scar formation in the heart. You'll get oxidative damage, and you'll get impairment in contraction. And all of these things will come together to produce this abnormal heart structure and function, which we've mentioned. And so as you can see, with ischemic heart disease, it's really a blood vessel disorder because we're affecting how the vasculature functions, whereas with diabetic cardiomyopathy, it's a disease of the heart muscle. And as I've mentioned, all of these can eventually progress into heart failure. So what is heart failure, and what is, this is the second slide of the question, what is the 5-year survival rate for heart failure? So I managed to make this one an actual slide on its own, and we'll give people a couple minutes to take a guess.
Polls open there. Nicola, if you don't mind, I might just relay what people are answering,
Yeah.
just in terms of that switch over time between the two profiles. So I'll give you a bit of a commentary. We've got we've got a bit of a split vote, actually, 3-way split vote between the upper 3 there. Right, okay, it's settling down. Yeah, most popular answer is the 65% at the moment. But there are answers for all clustering around. Oh, and now that we've said 65%, there's a few people joined the 65%. You often get this as well when we display them. So yeah, 65%, 41% of you said 65%.
Cool. So it'd be great if the answer is 65, because that's a little higher than it actually is. The 5-year survival rating for heart failure is about 45%. And so what this statistic means is that if somebody is diagnosed, or if everyone who's diagnosed with heart failure today, 45% of them will be alive in 5 years, which is a very low number. It's on par, it's worse than leukemia, it's worse than breast cancer, it's worse than most cancers. And I feel personally, in my experience of working with patients and people and families, heart failure is not as appreciated that it is a sphere of a condition as it may be. And the issue with it is it's a disease that we really don't have good treatments for, other than a heart transplant. And not everyone, we don't have a lot of hearts to give to other people, and not everyone's eligible. So heart failure is really a disease that, since we can't manage, we need to prevent getting to, because there's nothing we can do, unfortunately. So hopefully, if you're interested in this field and area, you can come join the research battle to kind of address it. So as I've kind of mentioned, heart failure, its simple definition, it occurs when the heart can't pump blood, or when it can't pump enough blood to meet the body's needs. And the way we define heart failure, or kind of where we cut it off, is by this statistic or number known as the ejection fraction, which is the percent of blood that the heart pushes out during each heartbeat. And normal is about 50 to 60%. So if the heart normally opens up and takes in 100 milliliters and contracts and pushes out 60 milliliters, that percentage is, it's pushed out 60 milliliters. When it had 100, it comes out to 60%. And the reason I harp on this point is because we use ejection fraction to subclass or subtype our heart failure. So we have one type, which is a heart failure with a reduced ejection fraction, where the heart is no longer able to contract, and this percentage drops down to less than 40. So if the heart is still able to fill to 100, it can't contract well, so it maybe only pushes out to 20 milliliters, which gives us an ejection fraction at 20. And those 20 milliliters per heartbeat generally isn't enough to sustain the body's circulatory needs. The other type of heart failure is heart failure with a preserved ejection fraction, which is sometimes a little bit harder for people to wrap their mind around. So here, you're still in heart failure, but your ejection fraction is normal. And the reason this occurs, it's because it's a problem with filling the heart and not actually contracting the heart. So before I said the heart normally fills to 100 mils. What happens in this type of heart failure is that the heart only fills to 40 milliliters because it can't relax, or because it's really scarred. And it can still contract, let's say, to push out 50%, But now that 50% represents only 20 milliliters and not 60. And as we previously saw, that 20 mils is not enough to sustain the body. And so when we have heart failure with a reduced ejection fraction, that's generally seen as a problem contracting, whereas this other type of heart failure is with the problem relaxing in the heart, so we can't fill it as well. And the difference comes is that they have different causes and they have different treatments. So this first type of heart failure is caused by heart attacks, and the way we treat it is with drugs. The details don't matter, but we have stuff we can give people. Whereas when we have heart failure with a preserved ejection fraction, it's normally caused by diabetes, and the issue is that we have nothing to use as a treatment. So in addition to having no cure, we have nothing to treat either. We can't delay the progression, we can't slow it down. And as you can see, diabetes and high blood pressure as two causes of this type of heart failure are quite common. So it's a huge unmet clinical need that a lot of people are trying to understand better because we can't do anything about it. And that is really concerning given how serious of a condition heart failure is and how common the two causes of these diseases are. So kind of circling back, we've talked about diabetes, we've talked about heart disease. How are they connected? Why does heart metabolism matter? This is really the linking portion of the talk where we start kind of seeing how does A lead to B. The heart, as you can probably guess, works a lot each day. It pumps about 7,000 liters of blood and needs about 5 kilograms of ATP, which is an energy molecule. And so it needs about 16 times of its own weight in this tiny little chemical molecule in order to be able to sustain its function. And to do this, the heart will burn any fuel source you give it. So it'll burn glucose, it'll burn fats, it'll burn all these other types of substrates in order to produce ATP. And about 30% of ATP production will come from glucose, about 60% will come from fats, and about 10% from anything else. And the reason the heart will break down anything you give it is because these different substrate molecules have different properties. So if we just look at how much energy we can produce, one glucose can give us about 32 ATP, whereas one fatty acid will produce about 130. So that's obviously a lot more energy per molecule. However, glucose is a little bit more oxygen efficient than fats, and so the heart will kind of balance glucose metabolism with fatty acid metabolism based on what's available, how much oxygen is present, what hormones are in the pathway. But the real key point here is that the heart needs a lot of energy. It'll burn whatever you give it, and it has this ability to switch between fuel sources when the person is healthy. And the way this happens in the cell is that, this is the only diagram I have with a little bit of a signaling pathway, is that glucose is outside the cell. It'll get taken up by a transporter and broken down through glycolysis into this molecule called pyruvate, which will end up in the mitochondria and broken down into something called acetyl-CoA. Fats, on the other hand, are also outside the cell. They'll be taken up by a different transporter into the cardiomyocyte, and fats can either be stored as these triglycerides, or they can, again, go into the mitochondria, undergo a different breakdown pathway called beta oxidation to produce acetyl-CoA. And this acetyl-CoA is the common point between fatty acid metabolism and glucose metabolism, because after here, it feeds into the Krebs cycle, then the electron transport chain to produce ATP. And that's as much detail as I'm going to go into because anything further is not important for us. But what I really want to show here is that although glucose and fatty acids are different fuel sources, eventually they feed into a common point to both produce ATP. And of note, fatty acids can be stored as these triglyceride molecules in the heart, and that becomes important a little bit later. So I've shown that the heart can use glucose. I've shown that the heart can use fat. How does the heart decide which one we want to use? Well, it really depends on what's available, because you can't break down something if it's not in the blood, how much oxygen exists, and then what hormones are present, such as insulin. So as we saw earlier, after a meal, we'll have high blood glucose, we'll have high insulin, and these things together will tell the heart to switch to glucose. It's present, the signal is there to say, hey, let's use this, so we're going to switch over and activate pathways for glucose metabolism in the heart. But when we're fasting, in the middle of the night, your blood glucose levels drop because you haven't eaten a meal, our insulin levels will drop. And as such, the heart will then switch over to fatty acid metabolism. So between what's available and what hormones are present, the heart will say, let's do glucose metabolism, let's do fat metabolism. And these processes within the cell, there's pathways which inhibit this glucose. So there's pathways within heart cells which inhibit the reciprocal pathway, because you never want to have both of them going. It'd be like hitting the gas and the brake in a car at the same time. It's just not efficient. And so I'm circling back to this idea of metabolic flexibility, which is the ability of the heart to adapt to different substrates. As we can see here, when glucose is present, the heart can use glucose. When fat is present, the heart can use fat. And it's really this ability to switch between one fuel source and the other that ensures that the heart always has the energy it needs to do what it needs to do. And in disease states, the loss of this metabolic flexibility is what really drives problems. So what happens in type 2 diabetes? We saw at the beginning that there's an increase in blood glucose and an increase in insulin. And based off the previous slide, this should signal to you, hey, the heart would probably use glucose. However, in diabetes, the heart is insulin resistant, so it doesn't see that insulin is increased. Similarly, as we talked about at the beginning of the presentation, the fourth kind of common feature to diabetes, in addition to high blood glucose, high insulin, and insulin resistance, is an increase in blood lipids. So because the heart becomes insulin resistant, it doesn't see the increase in blood glucose or the increase in insulin. What it does see, and what it only ever sees, is high blood fats. And so it switches to fatty acid metabolism because it doesn't see that there's any other fuel source. And from then on out, it only metabolizes fats. So it loses that metabolic flexibility to switch back and forth because it can't see insulin anymore. And this exclusive metabolism of fatty acids leads to problems. And this is what drives disease in the heart. Initially,
Nicola, if I can just interrupt, with apologies. I normally wait until the end for questions, but I think we've got a question here that kind of is relating to sort of explaining something as we go along. So please, could you explain how glucose is more oxygen efficient?
Absolutely. So I'm going to switch back a couple slides. I think that'll help. So in this process here, ATP, as I've shown, is produced from the electron transport chain. ATP can also be produced from glucose in glycolysis. I just didn't include this in that diagram to simplify it. And glycolysis does not require oxygen. So we can produce ATP oxygen without oxygen if we're going down the pathway of glucose. Whereas with fatty acids, they have to go into the mitochondria to produce ATP. And so the ATP produced from fatty acids can only occur through the electron transport chain, which requires oxygen to be present. So if someone has a heart attack, for example, and you lose all oxygen supply to the heart, if you were to rely exclusively on fatty acids, you would not be able to generate any energy or any ATP because the mitochondria, because you would have no oxygen. Whereas with glucose, you can increase your amounts of glycolysis, which here do not require oxygen to produce ATP. And so if you're looking at how much oxygen is required to fully break down a molecule, you generally need less oxygen per molecule of glucose than per molecule of fatty acid. Does that help answer that question? I don't have an ideal slide for it, I apologize.
To these ears it does, and I assure you, Nicola, I'm really discovering what a, oh, you've got thumbs up coming up, yeah, good
Thank
stuff.
You. I'm just going to jump back to where we were. So we were chatting here. What happens in the heart with diabetes is that it loses its ability to switch between glucose and fats. And over time, I've told you this is problematic. So why is that? Initially, there aren't any problems. But of course, diabetes is a chronic disease that goes over many, many years. So as the disease progresses, this leads to a decrease in cardiac efficiency. And this relates to actually the oxygen consumption, which I just explained. Because the mitochondria over time will get damaged and they'll become dysfunctional and they'll start to break down. And as a result of this, we'll lose those organelles, which we need to produce ATP. So we'll have very high levels of fat in the body or in the heart, but we won't have anything to do with that. And as a result of that, what happens is that we end up starting to store fat within the heart cells, just like a fat cell. So I bring back this picture here on the right, and in the bottom here is where the fats get broken down. But if this breaking down process stops to work, what happens eventually is we start shuttling the fats into storage and they only ever get stored within the heart. And this is because the rate of fat delivery is still high, but we end up losing our rate or decreasing our rate of fat breakdown, and we get storage of fat within heart cells. And the storage of fat within the heart past any normal level is quite problematic. Hearts are made to contract, they're made to burn things, they're not made to store fat. That's the role of the fat cell. So what happens when we start building up this intracellular fat? Or what happens when we start getting lipotoxicity, as it's known? Sorry, the slides aren't progressing. Richard?
Yeah, I've got the slide 19, the one with the pink and grey diagrams. I can't access that one, but we're on slide 20, aren't we? I think I'm controlling it, Nicola, if that makes sense.
Cool. Could we, because I'm trying to get on slide 20, I omitted 19.
Yeah, that's fine. That's great. That's what you want then. I just progress. Whoops, sorry. I just progress this. I'm coming back. Yeah, there we go. Yep.
Sorry, I'm trying to click and it's not progressing in front of me.
I think I can take control to you. Here we go.
Sounds good.
Have you got a take control button at the top?
Yes, I do.
Yeah, you take control. Great.
Excellent. I'll just skip back here. There we go. So as we've mentioned, we have an increase in fat delivery or increase in blood lipids to the heart, and this leads to this inappropriate fat storage within the heart cells. And when we start storing a lot of fat within the heart, they end up being shunted into different pathways. And one of them is the synthesis of bioactive lipids. So I'm not sure how much biochemistry you guys have had, but traditionally, when we talk about fats, they're generally used as components of the plasma membrane within the heart or as fuel sources. But there's also a role for fats to act as signaling molecules. So they'll interact with other molecules in the cell and start to change their function. And when you have a really, really high level of fat within the heart cells, you're going to get a really, really high level of these signaling lipids, and that's going to cause an absolute mess within the cell. These lipids can lead to further insulin resistance in the heart to kind of cause a positive feedback loop. They can actually cause the heart cells to kill themselves and induce apoptosis. They can reduce the force of contraction of the heart, so we get a worse pumping action. They can change how certain genes are expressed. They can change other signaling pathways. They can induce tissue remodeling. And what that means is we can get an increase in cell size, or we can start getting fibrosis or scar formation in the heart, as well as these lipids can change how the heart muscle responds to the nervous system. So as you can see, these lipids or bioactive lipids cause a whole bunch of problems within the cells. And it makes it really hard to treat this disease, because how do you design a drug that addresses all of those changes? Many of them are subclinical, which means we can't detect them with current medical imaging or blood tests. If you think about the changes I've been talking about, these are all happening within every single heart cell, but you can't measure the activity within a heart in the clinic. We don't have an imaging device. We don't have a blood test for that. In addition to that, and I know this kind of spoils the next question, unfortunately, these processes go on for 10 to 20 years before somebody presents to a doctor. So they're occurring and they're going so far down the line that by the time somebody presents to the clinic, these changes may be irreversible because you've been having heart tissue remodeling for 20 years, or you've changed how the heart and the nervous system interact for 15 years. And how does a drug reverse all of those changes that have occurred? And that's just the story of the fats. It's beyond the scope of this presentation, I haven't talked about what the high glucose does to the other tissues. So we've been talking about lipotoxicity, but in the body and in the heart and in other organs, they'll also become overwhelmed with glucose, and that'll lead to something called glucose toxicity. So it leads to the question of what do we do and how do we help? And where is research going with this? To kind of broaden this picture a little bit further, as we've mentioned, diabetes affects every organ in the body, and it leads to effects. There's issues with the lipids and there's issues with the fats. And I really want to kind of broaden the scope here. So the cells or the tissues that are normally insulin sensitive they generally become lipid overloaded. We saw that with the heart. That also happens with the liver, and it leads to non-alcoholic fatty liver disease, which you may have heard of. And then the fat cells can also become lipid overloaded, and they'll end up storing so much fat within them that they'll become inflamed and damaged, and they'll feed into this inflammatory fat phenotype, which underlies the development of obesity and some of the complications that occur with obesity. In the organs that aren't insulin sensitive, they'll also have consequences. But what happens in those tissues is they'll end up taking in so much glucose that they'll become glucose overloaded, and this will lead to problems. So this glucose overload in the brain, for example, has been linked to dementia. In the kidney, it's been linked to chronic kidney disease or diabetic nephropathy. And then even in the skin, which you would maybe think wouldn't be affected by diabetes, these really high levels of sugar lead to increased rates of infection, increased ulcers, and they can also slow down wound healing. And I really wanted to put this up here to kind of highlight that although I've talked about the heart and how the lipids affect the heart, it's every organ that's affected, and a lot of these organs have similar mechanisms underlying the disease. So in some ways that makes it easier to treat, but also harder, because if you want to do a heart transplant, you might fix the heart, but you don't fix the liver. Or if you give someone a kidney transplant, it doesn't affect or doesn't improve or fix the issues in the other parts of the body. So it really kind of drives home, this idea of how do we fix this and what do we do? So in terms of current treatments, what is the standard of treatment for diabetes is to encourage people to take their medication, to help with lifestyle modification, to increase diet and exercise, and to make sure patients aren't lost to follow-up, because some of these diseases tend to develop over 10 or 20 years. If we have good and careful monitoring of the patients, we can catch them as early as possible, and catching patients earlier generally leads to better outcomes. In addition to what physicians can do, or doctors or people, there's a huge role in prevention of diabetes. And this comes, again, a bit of public health work to provide people with the tools to make healthy choices. But when I say tools, what I really mean here is to start addressing the issues that underlie, some of those unchangeable factors that I talked earlier. Give people better jobs that have less stress, help people get better sleep, start looking at income so that people can have time to exercise, make sure that they can buy, the healthier foods. And I think oftentimes when we start looking at diabetes, especially in America, which is where I'm a little bit better, it's a little easier for me to comment on, it's looked at or treated as this individual disease. You've made these poor choices, but if you look at the cost of some of these things people are recommending, it tends to be very difficult. And it's been shown in some areas that if you start addressing things like food deserts or poverty, that can really decrease the rates of diabetes. And so although this talk is talking about some of the pathophysiology that underlies it, diabetes is a condition that permeates multiple other fields, because there's a huge social and personal factor to even treating the disease, which maybe goes beyond the border or isn't classically recognized in medicine. So kind of looking at future research in the area, there's kind of three broad categories. We still don't fully understand how the disease develops. And so a lot of research, and this is part of my work, is to understand how does it develop. And then when we understand how it develops, that will potentially give us new targets that we can try to activate or influence with the drug. Another major area of research in diabetic heart disease is to improve medical technology to identify patients sooner. So looking for new biomarkers or trying to improve our imaging quality to really see those changes within the individual cells. And cardiac MRI imaging is a huge and up and coming area here. So that could be something you do further reading on if you're interested. And then finally, the big one is to try and improve treatments and find an ultimate cure. Because the current treatments for diabetes can be quite expensive, they can be really difficult for patients, and they have a really negative quality of life. And ideally, if we could improve those, that would make this condition a lot easier to live with. And so just wrapping up here in the last couple of slides, I'm kind of unique in the sense that I straddle both research and medical practice. And so I wanted to give you a bit of my own personal pros and cons for why I like research and I like medicine, and what kind of factors I considered when I made my decision of one or the other. What I kind of liked about medicine is that you get immediate results. If you treat a patient, if you see them, if you're in the hospital, you'll do something today, you'll get a result potentially today or tomorrow. It is a very stable career. You will have a job for a very long time, and you get to work very closely with people, which is what I like and what's important to me. On the other hand, with research, what I like is that I get to pursue my interests. If you're a doctor or a physician, you don't get to see or choose who's going to walk through your door. Even if you're a specialist, let's say you're working as a cardiologist, you don't get to turn somebody away with a valve disorder because today you're in the mood to treat somebody with arrhythmias. You're a little bit at the mercy of whatever comes in through your, whatever patients appear, because you have a duty to those people. Whereas with research, you have much more control with, my interests, what I care to do, where I want to pursue my time. And I really like that and value that about that research, because I think it's nice to be able to pursue your interests. And similarly, I think in research, you get a chance to mentor and to teach people that isn't always present in medicine. On the cons, as I mentioned with medicine, I think you have less control over your day-to-day, and this definitely depends on subspecialty. If you're going to surgical fields, if you're going to clinic, there tends to be a lot of admin work. And with medicine, I would say it is harder to relocate internationally, but it is easier to relocate within the country. So if you're looking to move, that may be something to factor in to your decision. Similarly, with research, it is a very competitive field. There's not a lot of money, and there's a lot of people who want money for research. So you are constantly fighting to convince people to pay you to do what you want to do. And it tends to be a lot of laborious work for a single result. So oftentimes people will be putting in work for 3 to 5 or 7 years for one paper or one publication or one output. Whereas with medicine, it's much more, you do it today, you do it this week. So different things that factored into my own personal decision when I was looking into which career I want to pursue. And then finally, any further reading or questions. So as kind of Richard and I made our slides separately, so I didn't know which he was going to suggest. So there's quite a bit of overlap, which was kind of funny. So I won't kind of touch on those. But the last two, I think, were kind of, I didn't see in Richard's presentation. So I know at Oxford, there's something called Nuffield project placements, which are research placements for high school students, I believe. There are likely similar kind of placements to universities closer to you. The experience of joining a research lab or pursuing this is definitely much more important than the prestige of the institution you're attending, because it'll give you so much more substance to talk about in your interviews. So if some of the sciences are an area you're interested in pursuing, you could look into seeing if some of these research projects or research internships are available to you as a way to gain a little bit more experience in the field. And in terms of research articles, there are these types of articles called news and views articles, which I would recommend, because these news and views are a quick 1 to 2 page summary of an influential paper that has been recently published. So it's a quick read that has been summed up by somebody who's an expert in the field and can give you a really nice intro to maybe a more complicated paper before you get into it. Because even I find that sometimes you'll pick up a research paper and it's quite laborious to read it. So these news and views tend to be a much quicker, much easier read. And I think they'll still give you some of that substance or depth that Richard was talking about at the beginning of this talk. So I think that's everything I have for you guys. If you have any questions, please feel free to put them on the Slido, and I'm happy to answer.
Nicola, can I just say for now? Can I just say for now? That was a perfect example of the sort of depth drilling down a really also interesting issue. Brilliant. And you can see. I love the fact you've recommended some very specific resources there, and I'm gonna do what everybody does and borrow those ideas and take them into schools. So thank you from me as well. What is your opinion of 3D printed hearts? Since this is such a prominent and detrimental disease, is this the future?
3D printed hearts. I think it's an option, but I think it's not an option in the near future. I think when we're looking at 3D printed hearts in terms of transplantation, there's always the initial question of do they function well enough? And then if they do function well enough, how do they integrate into the body? So, and then also the whole issue that comes with transplantation of immune rejection. So I think they're an interesting way to try and address the shortage of organs. And it's an important one because I think finding organ shortages are a huge bottleneck in transplantation. However, I think there's a lot that's unknown and a lot more research is needed to figure out, are these a good enough substitution for other hearts? And I think that is an area that's quite unknown at the moment.
One from me, if I may, I just have to ask this. I've heard of kitty cuddling before, as in going to an animal shelter and cuddling a kitten that's not being looked after. Mm-hmm. Baby cuddling.
Yes.
Tell us more.
So to kind of put it into perspective a bit more, the hospital at the U of A covers all of Western Canada as well as the northern provinces. That's a huge catchment area. And so many times, and it is like for example, Edmonton is the second largest transplant center in Canada outside of Toronto. So for a lot of more extreme or unique medical cases, we'll have families and people coming in from out of town to Edmonton. And sometimes their families can come with them, but sometimes they cannot. And you'll have children or babies who are in the hospital on their own because nobody could join them. And so they'll have these child life volunteers or baby cuddlers to go and play with children or cuddle the babies because the nurses are quite busy and they can't always take the time out to cuddle or do something with the child. And this is a quick way to improve their stay. And it's been shown to reduce hospital stays, improve the baby's well-being. And it's just a way to kind of help entertain these children while they're in hospital to try and make it a more pleasant experience. Because if you're in the hospital as an infant, you're very likely going to have a lot of contact with the medical system growing up. And it's just trying to make this as positive or as favorable of an experience.
That's amazing and really moving, if I may say so. When we had twin boys and one of them was downstairs in an ICU and one of them was upstairs with us, I would have loved the idea of somebody going in and cuddling the one that was on the ICU rather. Do you know of any good resources, ideas for supercurricular research in medicine? I think you've just covered a good couple there, haven't you? I mean, certainly the project placements you're talking about. For supercurricular research, I mean, the news and views articles, that was new to me. I thought that was a really great tip. I think you've probably mentioned a couple of specifics. Anything else you'd mention? Because that question's been asked, but I think you've covered it really.
Any other kind of extracurricular placements? I think those are the ones that come to mind initially.
Yeah. You've answered it really with those couple of particular tips, absolutely. Which, as I say, I'm definitely going to borrow. So thank you for that.
By all means.
Nicola, thank you so much. It was passionate, it was so detailed, and brilliantly so as well. Really lovely explanation as well as something that's so crucial. One question for me, just in terms of just to draw it to a close. It's a $64,000 question, I guess. Why is it on the increase so much? The types of diabetes that you were discussing right at the start, or if you knew the answer to that, would that be?
I think it's a mixture of factors. One, we've generally become better at treating many other diseases, and so I think we all have to die of something, and we all eventually will develop something, and our bodies do deteriorate. So as we become better and better at treating other things, more people will end up with diabetes. An example of this is how many people used to die of infections until we developed antibiotics. Now nobody dies of antibiotic, or very few people die of infections, and other diseases have kind of started coming up. So I think that's one factor. And then the other one is just the amount of the lifestyle Western diet that all kind of come together, that are enriched in high levels of saturated fat, or they're very high in calories. And I think those things come together to predispose you to these to diabetes, if that makes sense.
Brilliant. Thank you so much. Can I just say as well, you've avoided the sort of judgmental approach that the media would probably, as you indicated at the start when you were discussing particularly type 2 diabetes. Just wonderful presentation. Thank you so much. Thank you for all your questions from attendees as well, and we will, of course, we have been recording this will be available on college YouTube channel in the next 24 hours, but I'll send a note to all those registered with the PDF and with the recording link too. Nicola, thank you.
Thank you so much for having me.
Cheerio. Good night.
See you guys.